I enjoy working in my field. To borrow a quote from a famous basketball announcer, you might figure out his name. What I do isn't like working, it beats working. It's something I have a passion about. And I enjoy working in this field because everybody knows a little bit about nutrition. It's applied universally every day, multiple times. And yet there's so much misunderstanding and sometimes confusion, especially when you get cancer. So my mission today is to talk about cancer and nutrition and what a patient can do and what a physician can look out for. So here's my objectives here. I'm just skipping through those because we wasted a few minutes here. So I hope you don't mind that. So this particular photo is able to get on the internet. You can get almost anything on the internet, right? And he just represents what some of my cancer patients look like. They're malnourished. He's got cancer cachexia. He's got the wasting away of the muscularity in the face. And so malnutrition or nutrition cachexia is common in patients diagnosed with cancer, and then it gets worse when they go into the cancer treatment sometimes. So the three areas that I want to focus in on today are prevention. Up to 50% of cancers are thought to be prevented by healthy diet. Then during treatment, which is what I want to focus on mostly today, it does help to support ongoing cancer treatment, whether it's immunotherapy or chemotherapy or surgical oncology. And then my patients come in with renal problems, with high blood pressure, with heart problems, IBS, and so many different comorbid conditions. And so nutrition plays a role in helping them be comfortable while they go through successful cancer treatment. Afterwards, survivorship. Two main goals I have in mind. If they've had successful chemotherapy, successful treatment to help prevent a recurrence, but sometimes we don't accomplish the cure or the progress that we're hoping for. And we're looking at comfort care and hospice care and better quality of life. So here's four areas that I think it pays attention to look at more carefully when a person has cancer or prevention versus during chemotherapy. The first one is protein. Oh, actually, that's the second one. Antioxidants. People are fond of, getting a lot of vitamin C and selenium and popping dietary supplements. During COVID, we heard about how vitamin C may help improve the immune system. Well, it is noted that vitamin C, as good as it is an antioxidant. And when we get antioxidants in high dosages in pills and capsules, that may actually interfere with cytotoxic chemotherapy and radiation. So we have to sometimes tell patients to tone down their dietary supplements, especially vitamin A, C, E, selenium, and so on. Adequate protein. Normally, we look at 0.8 grams protein per kilogram body weight, but during cancer treatment, because of the muscle wasting and cachexia and poor diet and malnutrition, we oftentimes need to bump it up a little bit. For the record, I'm not a protein pusher, but I find it valuable to help with the patient's energy, to help with erythropoiesis, blood cell formation, and boosting their immune system perhaps. And so getting a little bit of protein, how they do it with solid foods and meats or beans and vegetarian diet, and also protein drinks. So that's something I tailor to each and every patient. It's a little bit challenging sometimes. So nausea. Normally we don't think about nausea and vomiting, but during cancer treatment, it is a problem. So I've learned as a dietitian to support the ongoing use of many antiemetics, and it is valuable. For example, if I have a great nutrition plan, walk them step by step through healthy eating during cancer treatment, but they can't keep down their lunch, my plan is not very useful. So different ways of eating to prevent nausea and different antiemetics. Freedom with food, that's kind of a general phrase. What I mean by that is that patients are often afraid to eat foods that have sugar or carbohydrates because, as the internet says, Dr. Google says the sugar feeds the cancer. So even though that's an oversimplification, yet some of my patients take that to heart and they get a little bit paranoid. If my patient have a big problem with nausea or vomiting, anything they eat may cause them to throw up. If they have diarrhea, everything they eat goes through them. If they have constipation, everything they eat backs them up. That's from the patient perspective. And so I've learned to kind of navigate that maze with my patients and help them to kind of relax, enjoy the eating of food, enjoy some of your favorite foods, but there's some foods we need to avoid. So in generality, we try to make it more enjoyable. So having cancer along with the adverse effects of chemotherapy often make it difficult for patients to eat, to get enough calories, to get enough micronutrients as well. That's particularly troublesome with older patients. Now, older patients, what does that mean? I would just say generically over the age of 60. And even though I'm in that category, I think about my dad. My dad had some problems, some difficulties eating when he got older. And because of the way our brain ages, the part that controls thirst and appetite, the hypothalamus, that changes. So even without cancer, even in best case scenarios, some of my older patients, they don't feel like eating. They're not hungry. How many times have you heard that? I'm not thirsty. And getting them to drink enough fluids to be properly hydrated and to prevent constipation can be a challenge. So there's other issues, comorbid conditions, the pill burden, just taking handfuls of pills. Depression, patients don't want to be a burden on their family. So I have to try to factor all of those in when I see my cancer patients. Protein energy malnutrition is the most common secondary diagnosis with individuals with cancer. So it is not something that is rare. Depending on what literature you read, it may be 25 up to 50% of patients, many of those hospitalized. So it is a big issue. This is just kind of a fun little survey I did with 50 patients randomly selected, just to give you a feel for what kind of adverse side effects I see. Nausea and vomiting is right up there near the top. If I was to put fatigue, fatigue would be number one. Nausea and vomiting are up there. Taste changes, dyschezia, big time problem. Patients don't like the way their protein drinks. They don't like the way they normally eat the food. So we have to look at creative ideas. And then information, just asking about vitamins, supplementations, different herbs, different teas. What about the keto diet? What about the alkaline diet? And so on. As you can see, there's a lot that keeps me busy. So I want to go through about 9 different steps in terms of nutrition during cancer treatment. And we'll start with number 1. I want to support the patient. I want the patient to get the best possible outcome with their immunotherapy, with their surgical treatment, with their chemotherapy, whatever treatment they're doing. And so I want to help them prevent or manage malnutrition, as I've said earlier. I want to reduce patient distress, because when they're upset, when they're anxious, the joy of eating is often diminished. And I want to help them to be enthusiastic about their eating. Also, I can help them reduce missed treatments. If they're immunocompromised, if their platelets are bottoming out, if their energy is low, if they don't feel like even coming in for treatment, I feel like with good nutrition, we could support the health and the tolerance of the patient for chemo. And then manage the side effects, the electrolytes, the fluid intake, the protein. We discuss protein from a lot of the opioid pain medications, discuss protein foods for hematopoiesis to help the immune system. And if the immune system is weak, talking about how to support hand hygiene and to cook the food thoroughly so we can reduce the risk of foodborne illness. And so number 2, build up the patient's nutrition before the treatment begins. And I want to emphasize this: the sooner I can see a patient, either before they start treatment or in the first week or 2, we're going to get more mileage out of that interaction. We're going to get more buy-in. I have seen many patients after they've been so beaten down with their cancer or with their treatment, and then the cognitive part is very diminished. So it's very disappointing. Earlier, the better. So any physicians in here that want to send a cancer patient that's going to be starting treatment, send them to an oncology nutritionist. Patients with a lot of weight loss, 8 to 10% weight loss before their treatment, before their diagnosis, are more likely to have more common problems. Enteral feeding, it's a good way to get the patient on track, and that way they can go through treatment in a healthier state. That way they can tolerate the treatment and they can finish the treatment with better quality of health. And also to prevent cancer, cachexia and nutrient catabolism, lung cancer, pancreatic cancer, some of the GI cancers. The muscle wasting is profound. And if you worked with cancer patients with muscle wasting, sometimes you can see it in their face. Their weight may not change a lot due to edema or ascites, but it is very prominent. They'll come in walking in an outpatient basis, and after a month, sometimes they're beaten down and they're in a wheelchair. So there's a lot we can do to try to intervene with that. So here's some ideas to help with eating. And there are many of them, and it's a little bit like a 1,000-piece puzzle. So what works for one patient may not work for another patient, but I want to work as this is what I am. I'm an oncology nutrition dietitian, and there's board certification for that, CSO, Certified Specialist in Oncology Nutrition. So I want to develop a nutrition intervention, and I want to make it practical. Last week, I had an interpreter for a patient that spoke Arabic. I have no understanding of Arabic, so that was a challenge. I talk to patients in Spanish with my poquito español quite often because I want to tailor a plan to their culture, their language, their idiosyncrasies. So we want to expand the use of nutrition drinks. I'll talk a little bit more about that later. It isn't just, well, I want you to take 2 Ensures a day. There's a lot more to it than that. I want to clarify expectations about dietary supplements. So often the patients get distracted by all the different dietary supplements and vitamins that are out there, and it's ever changing. It's a field that's always evolving. So I want to get them to be focused on the macronutrients, keep their weight stable, get enough calories, get enough protein. And then after that, then we can talk about the micronutrients and dietary supplements. Okay. Also, friends, family, and care providers. Those are very, very important for the patient's care and well-being and support. So I want to get them involved. And I want to provide encouragement, hope, and empowerment. So when a patient has a stage 4 cancer, that's a dire consequence. It's a dire prognosis. They oftentimes lose hope. They don't want to be a burden on the family. And they just figure, well, if I don't eat, then I'll just make it quicker and for everybody involved. I'm not saying that's what most of my patients do, but I could see why that could be a mindset. So I want to give them empowerment. So preparing food, eating food is one area that I think patients can have a certain amount of control on. I also want to include follow-ups on a regular basis to help the patients manage their distress and to minimize missed appointments. So some of the medications are very available to help with boosting appetite. And this is just a short list of it. Dexamethasone is something that's used quite commonly. It does have side effects, but from the nutrition standpoint, it reduces nausea and can boost appetite. Marinol, which is a derivative of marijuana, can be very useful. And it can help reduce nausea. So I like a medication, not that I prescribe them, but I talk with my medical oncologist. Marinol can be quite useful. And then Remeron and Zyprexa are fairly newer medications. Clinical use is more for antidepressants, but I see them as being valuable for one-time use a day, or actually at night to be specific, and to help with sleep, to help with nausea sometimes, and to boost appetite. If my patient says, oh, I don't need that, I'm not depressed. Well, I don't go there. I just say, I'm not saying you're depressed. I'm just saying it might help with mood. So that way it smooths it over and it makes it a little bit easier for my patient to accept. Megace has been around for a long time. It's a hormone type of a medication that can help with appetite. Frankly, I haven't seen a lot of benefit with my patients, but it's available. Nutrition drinks, the positives and the negatives. People know about them, they recognize them. And so the benefits are they're easy to discuss with limited time. I talk about Boost, I talk about Ensure, maybe Premier Protein, if you've heard of that protein drink. And so they're easy to use as a snack. And I always remind my patients, this is not to replace a meal. We don't want you on a chemotherapy diet. We want it to be in between meals so we can add calories. So they tend to be energy dense, maybe 250, 360. Some of them are up to 520 calories. And this is in an 8-ounce portion. So they're very energy dense. That's the good news. Sometimes they're too heavy and we have to kind of tailor that. So they are modifiable. And I've learned a few tricks along the way to help my patients be more compliant with their nutrition drinks, because I don't push the nutrition drinks, but I think that they're a valuable tool. And so if they don't like the drink, the most common complaints I'm hearing are it's too thick or it's too sweet. And if you've sampled them yourself, you might be able to verify that. So if they like coffee, and I'm not pushing coffee or I'm not pushing caffeine, but it is a very beloved beverage throughout the world. Coffee is thin and it's bitter. So 1 or 2 ounces of coffee mixed in with a vanilla gives you a latte flavor and it makes it very palatable. And I've had, this is a little pilot study, not really a study, but study, more than 20 patients that are not using the drinks. It causes too much mucus, it's too thick, I don't like it. Why don't you like it? I hate it. You know, I want them to get specific. And about 19 out of those 20 patients, after he added a little bit of coffee to doctor it up, so to speak, they find out, I can handle this, I can drink this. And so we find one more tool that can be valuable. They're portable. So sometimes the patients, if they get a whey protein powder, they can mix it up at home. Or if they get a plant-based protein powder, they can mix it up at home. So the limitations are, I don't want them to be replacing meals with it. Sometimes they're expensive. So I'm always pushing coupons and handing out coupons and free samples. Sometimes the objectionable taste or thickness, as I mentioned. And sometimes they're a little bit on the high content with fat, with vegetable oil, with sugar. And I tell patients that if I was the CEO of this particular company, I might change it a little bit. But right now, if people ask me, how do I feel about these drinks? My one-word answer is, they're useful. It doesn't mean I have to like them, but they are useful. And there's a lot of things that we can do to make them more palatable. Okay, so using the antiemetics is very helpful. And I find out sometimes my patients, they're overwhelmed with information. And yes, they've been told by the doctor to use Zofran, ondansetron, or prochlorperazine, compazine, but they're not using it. Maybe they don't know how to use it. They don't know how often to use it. So I can kind of reinforce that lesson. And I find out my patients will respond to that. I tell my patients that nausea and vomiting is a very common side effect during cancer treatment, and that there is a trigger center in the brain and a second trigger center in the gut. So it's not unusual for my patients to be on 2 or 3 or even 4 different antiemetics. Now, I'm not saying that's good practice, but you know, if they're on scopolamine patch, they're on other antiemetics, we have to find out what works. And so that's all I'm going to say about that. So education is something that I'm doing all the time, and I want to support the role of the cancer treatment. And I also want to help them with comorbid conditions. So their cholesterol may be high. They may be on dialysis. We need to talk about a renal diet. They may have issues with diabetes. And so I'm finding out so many of my patients do have diabetes as a comorbid condition to go along with their cancer. Number 6, I want to help patients reduce fears of eating and preserve good feelings associated with food. I find it helpful for Christmas holidays, Thanksgiving holidays, for example, because my patients can have some access to unusual foods, foods that bring back good memories. And so I'm looking at reluctance. People are reluctant to eat because of constipation, diarrhea, nausea, vomiting, irritable bowel syndrome. If we had a time to sit down and talk about some of my most difficult patients with self-diagnosed allergies, self-diagnosed food intolerances, IBS, gluten intolerance, you name it, it can be quite challenging. And then, as I said earlier, some patients are afraid to eat because the sugar feeds the cancer. Simply stated, that's an oversimplification. And I'm telling my patients regularly to cut out the sodas, to cut out the candies, save the cakes and pies, donuts, if you will, for special occasions. I don't want to be overly restrictive because my patients, they didn't sign up for stage 4 cancer or stage 1 or 2 or 3. And I don't want to take away all of the foods that bring them pleasure, but I want to give them guidance. So looking at interactions with food and with supplements, because of time constraints, I'm not going to go through all of these, but you can appreciate them. Just today, I had a question about grapefruit. And I explained to this lady who had breast cancer. Even though it may not directly affect your treatment today or at this time, it's probably best just to avoid grapefruit juice and grapefruit right now, because you never know what the next phase of treatment may entail. Antioxidants, I talked about that briefly. And then there's all these confusing diets. Remember Atkins diet? Well, that's come around a couple different times. It morphed into the South Beach diet. Now it's morphed again into the keto diet, the alkaline diet, Acidic tea, the Gerson therapy. Just FYI, the Gerson therapy is a cancer-fighting diet based on raw foods, vegetarian diet, which I can't dispute that, it's beneficial, and also on handfuls of dietary supplements. And the doctor was an honorary doctorate. He never went to medical school. So that's something that I haven't had a problem with lately, but these things come up. Then maybe you've heard of Laetrile. If not Laetrile, B17. It's an alternative treatment that some people say is going to help cure cancer. By the way, it also is known as apricot pits, if you recognize it from that. So vitamins, let's talk briefly about vitamins. Helpful, counterproductive, too expensive. This was a study published in JAMA 2012, where the subjects in the study were physicians, 14,000 physicians. They were studied over a period of 11 years. And at the end of the study, it was concluded that there was a small but statistically significant reduction in overall cancer risk. And when you look at the multivitamin that used here, Centrum Silver, the cost is about $11, and that's for 90 pills. That'll last you for 3 months. So I think that there's no side effects. It's not high enough in antioxidants that it would interfere with our treatment. And for some patients, it has a little bit extra vitamin D. A multivitamin may have B1, B2, B3, some of the B vitamins that help with energy production. So I think that there's an upside with cancer patients taking a multivitamin, as long as it's not a mega vitamin, okay? So I just wanted to add that. So some basic guidelines about dietary supplements. Okay, number one, avoid more than 100% of the daily value of antioxidants. And there's other supplements, alpha lipoic acid, coenzyme Q10, that are included. So vitamin D, I'm sure you've heard that. It's very beneficial for bone health, but vitamin D also participates in the immune system. It's good for fall prevention, even for some cognitive health. So vitamin D is something that I recommend that people be aware of what their level is. And normally, I don't want to overprescribe or over-suggest, I should say technically, too much vitamin D. So 1,000 to 2,000 IUs is what I normally use. I think it's a safe and effective level. You don't want to overdo it by 4,000 IUs. That's the upper tolerable level, by the way. Okay, omega-3s, fish oil may be beneficial. Any other supplements, which I see a lot of, I do tend to tell my patient, hold off until you're completed with chemotherapy. By the way, if you're wondering how popular dietary supplements are, I'll tell you the patient that has the record for most dietary supplements in one day, 45 different dietary supplements. Can you imagine how expensive that would be? 45. This was a gentleman, a very interesting case study, a little bit narcissistic. Second place was a woman with about 35. So it is an issue, not with every patient, but it does come up from time to time. Here's a couple other things, alternative treatments. People that don't want to have chemo, they don't want to have surgery, they don't want to have radiation. It's understandable. There's side effects with that, but I do support what we do here at Loma Linda. So there's claims of cancer cures throughout the world. Mexico, India, Philippines, there's cancer clinics. One of these clinics in Mexico was the Donsbach Foundation. This was in the late 80s, I believe. And the company ended up being prosecuted, and they were guilty of misbranding, fraud, and unlicensed and unproved treatments. So some of my patients are overweight, and an overweight patient is sometimes unusual when you see them in the cancer clinic. You don't always recognize the signs of malnutrition or sarcopenic obesity. They may be losing a lot of muscle mass, but they're still very heavy. So I want to be able to work with them and talk about healthy, gradual weight reduction if that's appropriate for their type of treatment. And exercise. I like to promote exercise. I'm an exercise person myself. I was very disappointed when their gyms were closed because of COVID, but now they're open and people are going to the gym and not even wearing masks sometimes. Okay, so I have seen numerous studies that encourage regular exercise activity that helps with the patients tolerating their treatment better. So I'll just kind of leave it at that for now. One of the subjects I'm very passionate about is colorful fruits and vegetables. When I speak to my Spanish-speaking patient, I like to call it los colores de arco iris, the colors of the rainbow. And so photography is my hobby, and that's kind of why I like to include my slides. So when a patient's weight is stable and treatment is fairly well tolerated, I like to promote phytonutrients in a plant-based diet. You may hear it called plant-forward diet, same type of thing, mostly plants. Maybe sneaking in meat once in a while for a splurge. Those can provide numerous benefits while empowering the patients. The patients like the idea that there's something they can do to eat healthy. They like the idea of reducing inflammation with a lot of plant-based nutrients. So a plant-based diet rich in phytochemicals can reduce inflammation, provide cardiac benefits, promote several cancer fighting properties. And this is something I could spend hours on. As I was introduced today, I have done many food cooking demonstrations, and it's very engaging to look at a vegan diet, meaning no meat, no animal products. And I'm not saying they're bad, but that's our challenge, to do it on a vegan diet, to make it tasty, having robust flavors, a lot of colors, and provide numerous benefits for health. Okay, so I'm just going to skip over that. And by the way, if you have questions later, I'm going to allow time for that. When I'm talking about a plant-forward diet or a plant-based diet, think of the traditional Mediterranean diet. the traditional Asian diet, if you will. And this has been endorsed by the Adventist Health Studies 1 and 2. And there's a really good research article I'm going to show you in the next slide on this World Cancer Fund, the third expert report. Actually, 2 slides. So when we talk about phytochemicals, this is what I'm recommending. Lab and animal studies have shown phytochemicals to have the potential to do these following 8 different benefits. And I wish I could say we have a lot of human clinical studies. I think intuitively it makes sense, but we don't have the numbers. We don't have the data with human studies yet. Number 1, it stimulates the immune system. Mushrooms, for example, are immune modulators. There's a number of phytochemicals that will tweak the immune system to make it more effective, but also to be selective so that the immune system doesn't attack the patient's own body, like in a lupus or autoimmune disease. Number 2, phytochemicals block substances in food from becoming carcinogenic. Number 3, reduce inflammation that can predispose to cancer. Number 4, prevent DNA damage and help with DNA repair. Number 5, reduce oxidative damage. Number 6, slow or stop the growth of cancer cells to slow or stop proliferation and recurrence and metastasis. Number 7, trigger apoptosis. I enjoy talking to my patients about apoptosis if they're at that level of understanding, how sometimes the body has this mechanism already in place to target these abnormal cells and kill them so that they don't become immortal cells or the cancer cells. And number 8, help to regulate hormones as well. I talked to a patient today, had early stage breast cancer, estrogen receptor positive. And he said, do you like cruciferous vegetables? And oftentimes my patients don't recognize that term, but I say broccoli, cauliflower, Brussels sprouts, kale, brassica family, cruciferous vegetables. They have indole-3 carbinol that helps with hormone regulation. They also have another phytochemical called sulforaphane that helps reduce the first stage of cancer. So a lot of good stuff. Let me see if I can use the pointer here. All right, here we go. I did notice this week after I sent in this on email, this website here, National Cancer for Complementary and Integrative Health, it should be nccih.nih.gov. So it's missing NIH between NCCIH and .gov. That way you can get to it. You can still find it on the internet pretty easily. So one of my favorites is number 2, American Institute for Cancer Research. I'm recommending that to patients all the time. The website on this government organization has a wealth of data from human studies, from laboratory and animal studies to support the evidence of a plant-based diet and healthy eating. So all these are good. And if you want to have a fun time, go to Quack Watch. It's one that's been around for a long time, and it does identify a few physicians that are not doing what they should be doing. So it's kind of fun to look at. These are some books I recommend to patients, and the one in the middle is especially helpful. Whether you go into oncology or nutrition, it's just got a whole plethora of benefits. It has a section that I like to show to my patients. It's called culinary pharmacy. Culinary pharmacy. So you look in your cabinet at home at your seasonings, at your spices, your turmeric, your oregano, your black pepper, and so on and so forth. And it has a lot of interesting ways to incorporate those into a healthy cancer-fighting diet. So the goal, again, is to help patients maintain weight, support the immune system, tolerate side effects, and improve their quality of life. So I'm going to just have a couple slides on conclusions, and then we'll do some Q&A. So anorexia cancer cachexia and nutrition problems are pretty much inevitable with cancer and its treatments. It affects everybody, but some people in a very small way, some people in a major way. Proactive nutrition intervention is the best practice with cancer patients expected to experience weight loss, either with the cancer or with their cancer treatment. Number 3, involve an oncology dietitian to prevent or manage many of these problems. Earlier, the better. Number 4, positive nutrition information for maintaining weight and reducing inflammation tends to be well received, and it tends to be empowering for the patients. I don't want to be known as the diet Nazi, the person that takes away all the fun food that they like. I'll kind of give them what the research says and some guidelines, and I'll tell them what some alternatives might be. So number 5, encourage a patient to eat what they can with a plant-based emphasis and to get adequate protein foods. If possible, limiting red meats to 18 ounces per week. That's the rounding off for 500 grams. And this came from American Institute for Cancer Research website. And including snacks and nutrition drinks are very important. I like to get my patients on a schedule of eating every 2 to 3 hours. And that way, even when they complain about lack of appetite or early satiety, that way at least they're going to get enough calories. And for the nutrition drinks, I tell them you got to get your fluids in anyway. So why not get a fluid with a nutrition drink? That way you get some more protein as well. Healthy fats, monounsaturated fats, avocado, olive oil, nuts and seeds are something I'm recommending a lot of. And also the benefits from a nutrition consultation. I'm just going to skip through that except for the last one. Help reduce patient distress, reduce missed appointments, and improve quality of life. So that's, sometimes I feel like, you know what, I'm talking about nutrition. Don't we all know how to eat? Well, that's a rhetorical question. But I feel like I can at least shed a little bit of positive insight on why it'll be beneficial and give them a little bit more something to look forward to when it comes to eating. Lastly, I've learned that patients or people will forget what you'd said, and they do. People will forget what you did, but people will never forget how you made them feel. So I like this quote from Maya Angelou. Thank you for listening to me. And so I do have some time for questions.
Yes, we have a few minutes for questions, and we'll start with one from online. And if anyone else has a question online, I'll watch for that. She says, you recommended knowing your vitamin D level. What level do you recommend?
Well, there's a slight variance of ranges, but sometimes 30 to 70 is the range for vitamin D levels, and that's combined vitamin D2 and vitamin D3. So I recommend somewhere within that range. And if people don't know what their vitamin D level, I'm not a physician, so I don't order the test, but I do say, talk to your primary care physician or talk to your cancer physician and get that ordered, especially if they're at high risk for osteoporosis. Maybe they have estrogen receptor positive breast cancer, or they've got some significant weight loss or low BMI.
A couple of years ago, there was a discussion here about fasting mimicking diets and their effect on cancer fighting. Have you much experience with that?
I've read the literature. I don't have firsthand knowledge from any research, but fasting mimicking diet would be basically looking at reducing the carbohydrate, reducing the glucose to cancer cells, and forcing the body to run on ketone bodies. And that can have some benefits. Although I think that we need to kind of fine tune that. And if we're going to use it, it might be better designed for a person that can have a high degree of willpower, that can follow it properly. And so I think that we're not quite ready to roll that out yet, but I think it does have some promise.
Some people recommend high doses of vitamin D to prevent COVID and increase our immunity? What do you think? And is it different for cancer patients?
Well, I do think vitamin D needs to be on people's radar. I don't think that we want to be reckless with how much vitamin D we take. For example, vitamin D is a fat-soluble vitamin. And fat-soluble vitamins do get stored in the liver and the body fat, and it can reach toxic amounts. So having that in mind, I do tend to limit my patients' use to maybe 4,000 IUs a day. And the reason I recommend vitamin D supplementation is because my personal experience, I'm outside mowing my lawn, playing tennis, walking the dog, and in sunny Southern California, the sunlight strikes our skin and we should be able to generate enough vitamin D. Well, I was tested and I was low. So it's not always the case, so therefore vitamin D supplementation can be very reliable.
My older brother, class of 61, has CLL, used to not be much treated and go for years. Now it's not so innocuous. And his daughter, nurse, found out green smoothies work very well. So they concoct a lettuce and kale and a variety of green smoothie during the day. And his oncologist says, I don't know what you're doing, but it's working. You've improved 15% in the last couple of months. So we'll withhold chemotherapy.
Well, that's a good report. Green smoothies. I'm a fan of smoothies, but I like variety. So this morning, I didn't do a smoothie, but yesterday I did. I had 2 handfuls of green, and I like to choose baby greens because the absorption of calcium and some of the minerals is better in the baby greens. And then you can put in protein powder, you can put in turmeric, you can put in fruit, you can put in cauliflower, you can put in all sorts of things in a smoothie concoction. But I like to alternate, one day I'll have a mango carrot smoothie, one day a green smoothie, one day a berry green smoothie. So, there's a lot of amazing things you can do with smoothies. And keep in mind, smoothies, you're going to capture the fiber. So when you're juicing fruits or vegetables, you're removing the fiber. So I'm a fan of smoothies. Keep it up.
Thank you very much. Good questions and very pertinent presentation. Appreciate you being here.
Thank you.